So we're going to continue. This is part 2 of the post-op surgical nursing care patient. So let's get started. So this is continuing. Let's talk about drains. So when they operate on something, they're cutting someone open. There's fluids that go in. They're looking. There's blood. Sometimes there can be, if they've gone in and put in a stent or something, there could be drainage coming because of infection. Just different things. Air even could be in that area, and we need to get it out. It needs an outlet to get out, so a drain can be put in. You want to always protect your drains so that they are not pulled out. They're in there for a reason, and you don't want anything to happen to them. The other thing is you want to make sure you are protective of the drain. You're protected of the incision site, and we want to make sure that the dressing is over those. Things are handled, taken care of, and so that they don't get infection and we don't have any post-op issues. I'm looking for drains. Sorry, I want to make sure that I cover everything you need to know on a drain that would be important. To protect the suture lines, let me see, drains are used to protect suture lines, remove specific fluids such as bile. There's cerebral spinal fluid or drainage from an abscess. And then, of course, what I said previously, the accumulation of air or fluids from the operation itself. Some can be connected to something that can cause a suction to be able to pull it. Some are gravity. They're just there to allow it to work its way, just depending on the different drains. When it's ordered to remove a drain, a nurse can remove it. If you don't feel comfortable, have someone help you for the first time. They're usually pretty easy, but just like anything else, we would empty the drain if you can empty it before pulling it. And then you would want to make sure any sutures are snipped and that you pull very slow but gentle. But don't stop. Don't whip it out. And don't stop in between, because when you stop pulling something out, same with an IV catheter, when you stop pulling something out, you can cause the vessel or the area to spasm and it'll clamp down on it, and you don't continue to pull, you hold. Okay, sometimes when drains come out, if there's an incision there or you take off the sutures or out the sutures or whatever, steri-strips can be applied to reinforce, and that is, a doctor will let you know that. If you're concerned about an opening or something, you can put a steri-strip, but do talk to the surgeon about it. Okay. There are different drains. There's a Penrose drain, Hemovacs, Jackson Pratt suction devices. The Jackson Pratts are the bulb looking syringes, and we call them JP drains. You'll hear them called that. So here's different types of drains. The first one, A at the top, is a Penrose drain. B is a T-tube drain. You can see the T, how it makes a T. C is a closed wound suction device or a Hemovac. And then D is a bulb reservoir or JP drain, Jackson Pratt drain. That's what they look like. And you flip up the top and you can empty, and then you want to make sure you squeeze down the grenade in D and then put the little stopper back in so it'll create that suction again. The Hemovac's similar. You empty it and then you push it down and it will raise back up and fill. It causes that suction. So regarding the care of postoperative patient with the Jackson Pratt wound drain, what nursing intervention would be appropriate? Select all that apply. The answer is 1, we want to assess the wound drain for seal and patency. You want to make sure the drain isn't leaking or there's a crack in it or anything like that. 2, we want to measure the amount of drainage out of it. 3, we would want to compress the drain to reestablish pressure. Would we remove the drain? No, not it's not a nursing intervention. We wouldn't remove it without an actual doctor's order. It needs to maintain till they tell us to take it out. And then notify the physician if there's no drainage. JP drains don't always have a lot of drainage. Wounds don't always have, or incisional sites operate, sites where they put these drains in, they don't have a lot of drainage. Some will have none. You might have 10 milliliters in your shift, but they're there. You don't necessarily need to notify the physician that there's no drainage. You will document how much drainage you have. They'll be looking at that to decide, should the drain stay in or should the drain come out. So we want to prevent post-op complications. Wound infections. They can occur with any surgical procedure, because what are we doing? We're cutting open the largest organ that we have that protects us, the skin, right? We're accessing that. Signs and symptoms, remember that, of what are infection. We can have pain at site, redness, swelling, induration in the area, purulent drainage, fever, increased pulse rate. Will become tachycardic with that. We can have elevated white blood cells and swollen lymph nodes even from the adjacent areas. So those things can happen if we've got an infection. Usually, guys, when we see infection is 2 to 7 days post-op. Takes that time to develop. So it's so important that we share and teach our patient and family members that these are the signs and symptoms of infection, especially the things that they can see and feel, because most of the time patients are home when the post-op infection would occur. So we're not going to probably see it when they're in the hospital, but they'll get home and that's when they see it, and they need to call the physician's office if they have any of these signs or symptoms. Some subjective complaints that are indicate infection: fatigue, I'm tired all the time, loss of appetite, headache, nausea, general malaise or pain. Those are things that people can say, and we need to be tuned in that those could be signs that they have an infection going on. If they do have an infection, cultures can be obtained. And we would want to give appropriate antibiotics so that we know that we're killing whatever is in there causing the infection. Always remember, when doing cultures, we obtain a culture, if it's a blood culture or wound culture, before we start the antibiotic. And then you start your antibiotic. Always remember that. If they are an open wound, there might be irrigation ordered. They can, they'll want to put most likely sterile normal saline just to rinse out, pat dry, and then whatever dressing that they order, wet to dry, whatever they decide that they want to use to help heal this wound. If it is a non-infected wound, it should not be cleaned or irrigated with anything but sterile normal saline, because other things could irritate the tissue and slow the healing process, and we don't want that. Dehiscence or evisceration, this can take place. Dehiscence is when possible disruption or separation of some or all the layers of the surgical wound. It means when it starts to open up. Evisceration is when something is going to protrude or come out. We do not want either. We do not want a wound to dehisce because it's open up, and we do not want it to eviscerate. I had a patient one time that came in, and she was the sweetest little thing, and she had had open heart surgery. She went home. The sternal incision dehisced. It opened up and it was draining. So instead of calling anybody, it was small. So she took tissue and patted it dry, little Kleenex. And then it got a little bit bigger. She'd pat it and put a little bit of the tissue there to absorb it, to the point that when she finally did come in, it was a huge open infected wound that was stuffed with tissue that had become liquid, and ended up her sternum had to be removed due to infection of the sternum. It was just unbelievable. All because she didn't call. If something happens, if you have dehiscence or evisceration, those are emergent. That is when a physician needs to be contacted immediately. Dehiscence can occur at any time during the post-op period, but it most commonly occurs between the 5th and 12th post-op days. It's when the patient is feeling stronger and more active, but healing's not complete. Just so you know, in an abdominal incision, if they've had abdominal surgery, that usually the serous sanguineous drainage will increase prior to, so the dressing might be more saturated with that type of drainage before the wound layers will separate. It's starting to happen. Lots of times patients will state it feels like it's giving way. If somebody says that to you, you need to be checking that site, and you also need to be letting the physician know. And then FYI, those who are most or highest at risk for dehiscence or evisceration, guess what? Diabetic patients, shouldn't we know it? Obese patients, malnourished, they don't have the nutrients to heal, or dehydrated, or have a malignancy, have experienced multiple traumas to an area, to the abdomen, or have an infected wound. Those are the ones that are most prevalent to have the wound separation or disruption, the dehiscence or evisceration. Immediate post-op complications are respiratory depressions. They don't breathe. We have people not breathing. If we don't blow out or exhale the CO2, we hold on to CO2, correct? Remember when we talked about ABGs and that whole situation? If we hold on to CO2, then we're not going to have the right gas exchange. So we can, respiratory depression, what happens is it gets worse and worse and worse. Shock or anaphylaxis or hemorrhage. So we can either bleed out, we can have some form of shock depending on what's been done. And we'll learn shocks next semester. Anaphylaxis we'll learn next semester. We can have anaphylactic shock, because that's what that is. Or we just don't breathe. And then we get acidotic. And then we just circle the drain, unfortunately. So things that can happen. This is a great picture. This is a picture of where a wound is opened up, and there's evisceration where the wound is protruding. The whatever's inside's coming out. Looks like a monster, doesn't it? Just remember, if this occurs at home or even in the hospital, you want to moisten a sterile gauze with sterile water or fresh water if sterile is unavailable, and place it over the exposed bowel to keep the bowel membrane moist. We don't want anything to dry out if this happens, guys. We don't push it back in. Don't try to push it back in. You'll cause more harm, but we need to get something moist and protected. The exposed bowel, to keep the bowel membrane moist. Immediately notify the home care agency or surgeon, call someone for help. Have the patient lie supine with knees flexed and a moistened dressing in place. If the wound dehiscence occurs, notify the healthcare provider and follow the instructions given. I want to say that again. If this happens, you want to lay them down flat, put them down on the ground, put their knees up. They need a moist gauze or something over that to protect it. Do not push it back in. Whatever you do, don't try to pinch the wound back together because you think you can. Do not. Just cover it, and you contact someone immediately. If you're out in a field somewhere and this happens, you're going to have to do whatever you need to do. You want sterile water and gauze, because you don't want to introduce infection into this. They're going to have to go back in, clean it up, put it back in, and close it back up. So these people will be very prevalent to infection if this happens. So a lot of really bad things can happen, unfortunately, and there's different shocks. You'll learn those as we go along. I don't want you to focus on those. If they're in your reading, just ignore them. But go to malignant hyperthermia. I do want you to understand this. It's a rare but life-threatening complication of general anesthetics. So anesthesia can bring on malignant hyperthermia. What is hyperthermia? Our temperature is going to go high, right? High temperature. And when I say high, in the late sign of it, your temperature can get up to 111.2 degrees. It can go high. I mean, we're talking you're cooking. I mean, this is bad. If you don't treat a patient prior, pick up on things, but when that temperature starts to go up that high, they're not long for the world. They're going to have cardiac dysrhythmias, rigidity of jaw or other muscles, hypotension, tachypnea, and they're going to be breathing fast with a low blood pressure and a very, very high fever. We're not looking at it. What we do is we're going to use cooling blankets and ice packs. Let's get the temperature down. When your temperature is high like that, you can see she'll have seizures. You can also, you're frying the brain. I mean, literally in layman's terms. So we want to get that down. Ice saline IV solutions, these are all ordered by the physician. Cold solution enemas, we're bringing it down. But the drug, and a drug I want you to put on your list to learn for my students, is Dantrium. This is the drug of choice to treat malignant hyperthermia. So what happens is you want to look, it's very rare. We don't see a lot of people with it. I can honestly say as many surgical patients that I have recovered up in the ICU that I worked over the years, I never have seen it. But people who work PACU and stuff, I am sure they have. I just want to look at a few things just to make sure. The other symptoms that you could see with this is, and this is a key one, dark colored cola. It looks like Coca-Cola colored urine. That is a sign of it. If you see that in your Foley bag, you better be calling a physician immediately. That is life-threatening. We need to be calling the doctor. So you have that very high temperature, up to late signs of it up to 111.2 or higher. Notify the doctor immediately, the surgeon. They've got to be treated fast. This isn't something that you can take your time on. The patient will be immediately cooled down and given cardiac and respiratory support if needed. We've got to. So remember those symptoms. So once again, if you've got any kind of surgery that's going to alter their physical appearance, we want to promote psychological help, support these patients. They have body image issues, especially with scarring, and it's depending on age too. But I don't care if you're older, if you're male, if you're female, anybody that gets a bad scar or alters their body in any way, they're going to be concerned with it. And we need to understand that. It's not for us to say, oh, you're an old person, you lived your life, what's a scar, right? Now, there's some people out there like, this is cool, I've got the best scar ever. But there's very few of those out there. So you need to be very in tune to that. They can be withdrawn and have depressed behavior. They might have less attention to grooming than before. They might have been a person that has a mastectomy, but prior to the mastectomy, they got up, they did their hair, they always had makeup on, they looked, a certain way, and then all of a sudden they're not putting makeup on, they're not doing their hair, they're not talking about it, they don't want to talk about it. And so we want to continually to assess our patients for ineffective coping. They could withdraw, depressed behavior, of course. Just making sure that they get the help. We want to refer these patients to support groups. They're out there, and any other help that we can. And be the listening ear. be the one, open-ended conversations, and listen, but understand that they're going through something and it's difficult. And if you've never had to deal with that, then it's very difficult for you to understand too. So just remember to be the listening ear so that you can help them and get through it. Sometimes it's just talking it through. Now, discharge planning is huge. These patients are going home, they're on their own. So we need to know what they need. Assess patients' needs. Do they need food? Do they need Meals on Wheels because they can't go to the grocery store? What is going on with them? If their diet is totally inappropriate, do they need follow up with home health to do some teaching in the home about proper nutrition, stuff like that? Do we need a nutritionist, a dietitian to come in and get involved before they go home and work with them on diet? Activity, the same thing. Do they need physical therapy? Do they need occupational therapy? What activities should they do and what activities should they not do? And then the wound care, of course. And we want to make sure that we tell them what they need, how to do it, and what to do. And the best thing with that is to have them participate. Family members should participate. Patients, if they're going to have to do their own, they need to. We need to talk these things out and through to make sure that when they get home, their needs are met. I'm going to tell you something. Please hear me, all of you. This is a piece that has gone missing in care and healthcare today. It is something we are not seeing like we used to. It's like, here's your paper, sign the paper, you're out. Well, let me tell you something. It doesn't work like that. People get home, they can't figure it out, they try to read it. It's just hard. Provide them with the information they need so that they can be successful. Cultural considerations, we need to remember. Family involvement, do they have them? Significant others, maybe they're not married, maybe they have a significant other. However it works. If it's a best friend, whatever. Who and what is involved and how is what we need to know, and then we work with that. Always honoring, always being respectful, and always giving the information that's needed. Also, signs and symptoms to report. What signs and symptoms? Well, signs and symptoms of infection, right? Because we're going to see those. Signs and symptoms of dehiscence or evisceration and what to do. All of those things. Also making sure that they have a follow-up appointment. That's part of the discharge planning. That is part of them going home, that we already have the follow-up visit with the surgeon in his office so that they're not overlooked. So they're not left out there floundering and can't get an appointment. Those things need to be done ahead of the game. And then home care considerations. Do they live alone? Do they have to walk a flight of stairs and they're on a walker and there's no ramps? We need to know everything and get those involved and figure out what we need to do to get this patient back home and doing what they're supposed to be doing or have been doing prior to the surgery. These are things also to consider at home. Will they need assistance with their ADLs? Are they going to need help with their wound care? And we might have to get people to come out. And sometimes it's a nurse to do the wound care because they can do the other things. Sometimes we need both. We need someone to come out and assist with ADLs, helping them bathe and dress and all that, and a nurse coming out to work with the wound, work with IV stuff, anything like that. And also what equipment they'll need. If someone needs oxygen and you send them home and no one is set up for oxygen to be set up, it could be a day or two before the oxygen even can get out there. So we want to make sure everything's ready for them so when they go home, they're not put in harm's way because something was not set up for them. So we need to make sure if they need suction, they don't have suction or oxygen on a wall. We're going to have that brought from an equipment place like Lincare or somewhere like that. Same with IV pumps. Those things need to come out to the house, be delivered, and then the nurse will have to go out and help set things up and teach and show. So we want to make sure those things are in order before we send them home. Once again, home care considerations, just dot it out. Care of incision, diet requirements, proper nutrition, making sure they're getting the food, or maybe maybe they can cook, but they just can't get to the grocery store to get the food. There's ways of delivering food. There's different things we can do and help them get what they need. Any equipment, of course, we talked about. To schedule for deep breathing, coughing, and leg exercises, we need to prevent them from getting post-op pneumonia or hypostatic pneumonia, and also any kind of blood clot. They can't go home and just lay down or sit down in their chair and not move. We need move. Activity needs, and how much activity. Now you have some patients that want to go back to scrubbing the floors and doing the laundry. Well, that's not going to happen until they're at a certain place post-op. And so they need to understand that. Medications are huge. What they are to take, what they're not to take, when they're to take it. They might have come in on 25 medicines and they might be going home on 20. And they need to understand what they're to take and why they're not. Because some people really struggle with that. They're like, I've taken that for the last 20 years. Why would I not take it now? Well, you're taking something else, you know. So we need to make sure that they understand their medicines, when to take them, and to make sure that they get those medications, any new prescriptions filled. Lots of times bigger hospitals have pharmacies down and they can get their medicines filled, and they'll either bring them up to the room before they leave, or they can walk out and go through the pharmacy and pick them up as they go out the door. It's very nice. And then signs and symptoms to report. If there's any issues, problems, uncontrolled pain issues, if they've got signs and symptoms of infection, if we have any dehiscence or evisceration going on, any questions, but signs and symptoms of those things we need to know. The doctor needs to know. If they're feeling faint, if they're feeling dizzy, orthostatic hypotension, you know, things like that. All of that needs to be reported, and we would want to teach them. So there is precautions related to anesthesia. So they don't need to be using machinery right out of surgery. Even same-day surgeries and stuff. They're not to go home and use heavy-duty machinery. They don't need to be driving. Caution regarding making decisions for 24 hours. Anesthesia plays a lot. It stays in the body. It takes a while for it to get out. And so it can actually kind of cause issues with thoughts. And you don't want to make some big legal decision after being on anesthesia or having anesthesia. So wait 24 hours before you go jump and make a big trade on your stock market or sign your life away for something. You know, don't do those things. You need to wait. Drug interactions, there can be different drugs. If the anesthesia makes you very sleepy, you don't need to take anything else that will make you sleepy. They can cause constipation and urinary retention. So we need to make sure that they urinate and pee and poo, right? They have to. And so if they don't do it with you and they're going home, then you need to tell them they need to make sure when they get home, by whatever time frame that's given, 8 hours is the max, that they need to go to the bathroom. If that's not the case, and then of course the bowel movement is 2 to 3 days, right? Post. If that's the case, they need to understand that so that they can call if they need help. And if they don't have a bowel movement and they have one every day, and they don't have one the first day post-op, it's okay. They should be having one by day 2 or 3, as long as they're eating and things like that. And they're about, if not, they need to call a physician. They need to call the office immediately. If they're in the hospital with you, then we will intervene accordingly. So this post-op surgery, this is referenced back to the Medical Surgical Nursing Concepts and Practice book from Stromberg and Elsevier.